Greetings, dear learners. We will learn asphyxiant's poisons today. Lester Adelson, a famous forensic pathologist in USA, defined asphyxia as the physiological and the chemical state in a living organism in which the acute lack of oxygen is available for the cell metabolism and is associated with inability to eliminate an excess of the carbon dioxide. Etymologically, the term asphyxia, A means absence, phyxia means the pulsation. Absence pulsation, that is pulselessness. Yet in everyday uses, it denotes the lack of oxygen or the condition of the defective aeration of the blood, often described as exclusion of air from the lungs. Asphyxia initiates a vicious cycle that persists until the individual succumbs. The cycle of asphyxia begins with the decreased oxygen levels, leading to the capillary dilatation, stasis and the engorgement, which further reduces the venous decrease in the pulmonary blood flow that results in the deficient oxygen in the lungs. This decreases in the pulmonary blood flow, resulting in the deficient oxygenation within the lungs, perpetuating the cycle of asphyxia until the death. So, the ultimate effect of the asphyxia is that the body is unable to utilize the oxygen at the tissues level. Either it is because of the obstruction at the inhalation level or the absorption level or at the vascular level. So, on the basis of that, the asphyxia has been classified into non-mechanical asphyxia and the mechanical asphyxia. In the non-mechanical asphyxia, no physical blockage in the air passage is there. It can be the environmental. It happens in the high altitude, enclosed spaces or by the inhaling gases like the sewer gas, hydrogen and the helium. Then it can be due to the toxic inhalation of the gases or the chemicals that includes the carbon monoxide, cyanide or the drugs like the barbiturates, morphine, strychnine that can affect the oxygen uses at the tissues level. Then the pathological condition. Certain pathological condition may also cause the inability of the organs to utilize the oxygen, that is the laryngeal spasm, that is the basically mechanically obstruction of the inhalation of the gases. Then the pulmonary edema, in that case the exchange of gases is prohibited. Then the pneumonia and the tumors or the abscesses, all those conditions inhibit the exchange of the gases from the lungs to the bloods. And there can be the mechanical asphyxia, that is there is physical obstruction in the airway. So, in this way, the asphyxia effects on the body are seen. So, think like this, that from inhaling the oxygen, we are inhaling the oxygen from the air, and if the conditions and the conditions where the oxygenation of the lungs and the blood is not proper, how all those conditions may arise. That can be that we are inhaling that gas, what we are inhaling is not of adequate quality. It contains the lesser quantity of the oxygen. It contains the high quantity of the other gases, nitrogen, carbon dioxide, carbon monoxide, that results in the more of inhalation of the other gases than the oxygen, which is the actually required. Then after the gases that is in the surrounding that has been disturbed, then see the organs that are involved in the respiratory system. So, from the inhalation through the nose to the pharynx to the larynx, trachea and then to the lungs, all in between anywhere there can be the obstruction, like someone blocks the face, nose and the mouth in cases of smothering. So, this is the mechanical form of asphyxia. Then in certain cases where this pharynx is occluded, in the case of the choking, or the larynx is occluded where in the laryngospasm or in case of choking as well, and in certain vagovagal spasm, that in that case it is not the asphyxiation that is the major cause of death, it is the vasovagal syncope that is the causing cardiac arrest, sudden cardiac arrest that is involved. Although this is a gray area that has to be understood. Then other type of certain mechanical obstruction that's seen in the case of the hanging, strangulation, and there is a list of the classification of the mechanical asphyxia that you can see. Additionally, after inhalation, our chest is expanding. So, we inhale, the chest is expanding. If we stop chest from expanding, then also it may cause the inability to inhale. so the respiration is not proper. This may also result in the asphyxia, that is called the positional asphyxia, that is seen when the person, some heavy object is placed on the body chest, and then in that case, in the stampede and all those situations, the body is not able to inspire. In those cases, death is again due to the asphyxia. So this is basically the mechanical form of asphyxia. Then at the lungs level as well, there could be the damage to the lungs. In that cases, the exchange of airs could not be possible. So that could be the tumors, abscesses, pulmonary edema, pneumonia. All these conditions may prohibit from the exchange of the gases. Once the exchange of gases had happened to the blood, then in the blood, this blood, from the blood, oxygen goes to the tissues at the site of the need. Then at the site of the need, again some of the toxicants that may inhibit the electron transport chain or other systems that may inhibit from the utilization of this oxygen that is available in that. So various toxic gases, carbon monoxide, cyanide, all these we will be coming to know how they act and what is their mechanism of actions. In this way, they causes the asphyxia on the body. In this way, they are classified under the non-mechanical form of asphyxia. Then we must know the classical signs of the asphyxia, as these classical signs will be seen in all cases of the asphyxial death, whether it is due to the mechanical asphyxia or due to the non-mechanical asphyxia. In both the cases, the signs of the asphyxia will be seen. That includes the petechial hemorrhages, that is the small pinpoint blood collections that are seen on the various organs, that can be seen on the eye, conjunctival hemorrhages, then on the lungs, visceral surfaces. All those places, multiple petechial hemorrhages are seen in cases of asphyxial death. More is the asphyxia, more are the signs prominent. This results from the acute rise in the venous pressure. This is not exclusive to hypoxia, and the mechanical factors also influence the petechial hemorrhages findings. So in case of strangulation, petechial hemorrhages are more, whereas in case of hanging, this is on lesser quantity. Then another classical feature is the congestion and edema. Tissue swelling is due to the obstructed venous return. So the venous return that is getting obstructed, so everywhere the tissues get overloaded with the blood and the vascular supply, that causes the mode of the permeability and increase in the tissue fluid, that results in the edema of the various organs. So the congestion of the face and the different organs above which the venous supply has increased, all will show the congestion and increased tissue fluid, resulting in the edema. In asphyxia, edema is often associated with the congestion and it may not indicate the hypoxia alone. Hypoxia is a condition where there is a decreased supply of the oxygen, that is the different from the asphyxia. In asphyxia, it is decreased supply, whereas in asphyxia, it is total absence of the supply of the oxygen for any reasons. Then the third classical feature that is seen in the asphyxia is the cyanosis, that is the bluish screen discoloration due to the reduced oxygenation. It may not always reflect hypoxia accurately. All these features are not the accurate features, but the often seen with the asphyxia. In the cyanosis, you must be knowing the details of the cyanosis. So the cyanosis that is seen on the nails will be cyanosed, lips may be cyanosed. All those peripheral cyanosis may be seen in case of asphyxia. That is the important classical feature seen in case of the asphyxia. So to develop the cyanosis, it must take some duration of the asphyxiation. So the presence of cyanosis indicates that certain duration has expanded during the asphyxia. Then another important feature seen in case of asphyxia is the engorgement in the right side of the heart. This is due to the generalized rise in the venous pressure. Then the next important finding seen is the increase in the blood fluidity. This is due to the decreased activity of the fibrinogen that causes the fluidity of the blood. These all forms the classical signs of the asphyxia, although none of them are the specific markers of the asphyxia, and also they are common in all forms of the congestive deaths. In this way, we will be seeing these findings in all forms of the asphyxial death, whether it is due to the poisoning or whether it is due to the mechanical asphyxia. So the poisonous gases, they may also be called the toxic gases, that also causes death by the asphyxia. They will show the features of the petechial hemorrhages, congestion, edema, cyanosis, engorgement of the right side of the heart, blood fluidity, that all may be seen at the time of the autopsy as well and in the clinical examination. Then coming to our topic, that is on the asphyxiant gases. So that asphyxiant gases may be classified under the toxic gases. They are classified as simple asphyxiants, respiratory irritants and the systemic asphyxiants. The simple asphyxiants are those gases that displace oxygen from the surrounding air, diminishing the partial pressure of the available oxygen. The examples include the carbon dioxide, nitrogen, aliphatic hydrocarbon gases such as butane, ethane, methane and propane, and the noble gases like the argon, helium, neon, radon and the xenon. Respiratory irritants. These gases harm the respiratory tract by compromising the integrity of the mucosal barriers. As the name suggests, they irritate the respiratory mucosa. The examples include the acrolein, ammonia, chloramine, chlorine, formaldehyde, hydrogen sulfide, methyl bromide, methyl isocyanide, oxides of the nitrogen, osmium tetraoxide, ozone, phosgene and the sulfur dioxide. Additionally, gases associated with the heavy metals fall in this category, such as the cadmium fumes, copper fumes, mercury vapors, zinc chloride and the zinc oxide. All these are the respiratory irritants. Then the systemic asphyxiants are the gases that cause the notable systemic toxicity through the specialized mechanisms. Like they have in carbon monoxide, they combine with the hemoglobin and displaces the oxygen from them. And so the tissues are not having enough oxygen to utilize them. Similarly, in case of the cyanide poisoning as well, and in case of a smoke, it is important to know that the systemic toxicity may also manifest with some simple asphyxiants and the respiratory irritants, albeit, however, for them it is not a primary feature. So, in case of the simple asphyxiants and the respiratory irritants, they also produce their toxicity by the asphyxiating actions on the tissue level, but that is primarily not their feature. That is why they have been characterized into the simple asphyxiants and the respiratory irritants. In this way, we have to study the toxic gases. However, for our syllabus purpose and for our knowledge, we have to only know the limited gases. One we have to know is about the ammonia, hydrogen sulfide, methyl isocyanide, cyanide and the carbon monoxide. Those who are highlighted. So, we will be learning only the highlighted ones that had been in your curriculum. So, beginning with the ammonia. Ammonia is extremely irritant gas with a pungent odor. It is highly water soluble, forming alkaline corrosive ammonium hydroxide. So, here you can understand this causes formation of alkaline corrosive substance. So, as you have studied the corrosives, so all the features of the corrosive poisoning will be seen in cases with the ammonia. So, ammonium hydroxide poisoning features will be seen. Then the aqueous ammonia is a colorless with the pH of around 11.6 and it has urine-like a smell. This is used in the biological process as a source of non-protein nitrogen. Major source of non-protein nitrogen is urea, found in the range of the blocks, cubes and the feed mixtures. Other NPN sources includes the biurate, starch urea and the various ammonium compounds. It has been implicated in the hepatic encephalopathy due to its accumulation in the body. Factors like high protein diet and the gastrointestinal issues increase the ammonia production. It is used in the agriculture as a fertilizer, in mining industries, manufacture of the plastics and the explosive. It is used as refrigerant, cleaning and the bleaching agents, treatment of syncope in the form of the smelling salts. All these places it is used. So, it is easily available in the household and the industries where it can be consumed or the accidentally poisoning can happen. Then the mechanism of action of ammonia is that anhydrous ammonia as a liquid or gas mixes with the tissue water to form the strong alkaline solution called as the ammonium hydroxide. This reaction generates heat and causes significant tissue damages. Alkali-induced damage is severe and often penetrating deeper into the tissues compared to acids. We already see in case of the alkali and acids that the alkali causes more of the perforation and the damage than the acids. In a similar way, this is the whole mechanism is based on the strong alkaline solution. sodium hydroxide that generates the heat and it causes the significant tissue damages. And the features of the alkali toxicity is seen in the case of the ammonia. The fatal dose of ammonia is about 5 to 10 ml of the liquid ammonia, and in case of inhalation of the gases, a concentration above 5000 ppm can be rapidly fatal to death. Then clinical features seen in case of ammonia. In case of inhalation, it causes the severe upper airway irritation. The symptoms include the tearing, coughing, difficulty breathing, convulsions, coma and the death. It can lead to the glottic and the laryngeal swelling, bronchial mucosal damages and the lung inflammation. You can see here in the picture there is a rhinorrhea, eye irritation, skin irritation, lung tissue damages and the respiratory tract damages. All these features are seen in case of the inhalational or the dermal effect. Then in the chronic exposure of the inhalational gases, it can cause the reactive airway dysfunction syndrome, that is RADS. RADS resembles the asthma, but it is not triggered by the allergies. This is important to know that many times the patient who are working in such environment over a long period of time, they may have the toxicity of the ammonia. However, we may think that it is the asthma and the clinician will be keep on treating the him like an asthmatic patients. However, there will be not much benefit coming out unless the exposure environment has been removed from the patients in surrounding. Especially the chemical workers are at risk of this chronic RADS. The management of this chronic RADS includes the removal from the exposure source, that is the vital, and the treatment mainly focuses on the symptomatic management, and that is of much of helpful in those cases. Then in case of the ingestion of the ammonia, it causes corrosion of the digestive tract and the potential pneumonia. Its symptoms include the nausea, vomiting and the mouth or the throat swellings. Dermal exposure causes the deep burns on the skin. Anhydrous ammonia exposure, that is stored at the low temperature, it can cause the frostbite and the tissue damages, and those of the symptoms of the frostbites. Then on the ocular exposure, it causes the severe eye burn, potential blindness. The symptoms include the eye redness, tearing and the corneal damages. Chronic occupational exposure, as we already talked, it will present with the rats. Workers may experience chronic cough, breathing difficulty and the lungs abnormality, the symptoms mimicking the asthma, laryngitis or the lung fibrosis can occur due to the prolonged exposure. Then to make the diagnosis of ammonia, the chest X-ray is recommended for the dyspneic patients to assess the lung condition. Then early endoscopy is recommended to look for any damage that has been caused by the ammonia. Then barium swallow is performed 1 to 2 weeks later to check for the esophageal strictures. Then the confirmatory diagnosis of the ammonia is through the lab test. That includes that unknown solution or the stomach contents is placed near the concentrated HCl, and that results in the production of the white fumes of the ammonium chloride that confirms that the ingestion of the ammonia. Then also the various laboratory tests like chromatography, calorimetric techniques, then the secondary derivatives spectroscopy, airborne ammonia detection methods include the ammonia specific electrodes, and all those spectroscopy and the chromatography may be applied for the detection of the ammonia in the laboratories. So in this way the ammonia confirmation will be done. Then for the treatment, various exposure needs the different sorts of the management. For the ocular exposure, irrigate the eyes with water for at least 30 minutes until the neutral pH is reached. In case of the dermal exposure, wash the affected area with soap and water followed by the extensive water irrigation. Treat frostbite with the standard methods. Then in case of inhalational exposure, administer oxygen, positive end expiratory pressure, and the bronchodilators are recommended as we treat in cases of asthma. In the similar way, symptomatic treatment is done. Intubation or tracheostomy may be necessary for the severe cases with a stridor that is indicative of the laryngeal swelling. Partial liquid ventilation shows promise based on the preliminary studies. Treat bronchospasm and wheezing with the inhaled symptomatic agents, and even the steroids is a controversial. They may be recommended if it is not getting refractory to other managements, and in case the fibrosis of the lungs is developing. Then in case of ingestion, give a small amount of water or milk if the patient can swallow and protect the airways. Don't use vinegar or weak acid to neutralize. This is important as we will think that this is a strong alkali, so it may be neutralized with the weak acid. However, it shall not be done. Then avoid diluting milk and water if the patient has respiratory distress or altered mental status, severe abdominal pain, nausea, vomiting or inability to swallow. Don't use activated charcoal or induce vomiting. Consult for endoscopy promptly and ideally within 24 hours is needed. So, in case of poisoning, it is more important to know what not to be done than what to be done, because giving the unnecessary things and the unnecessarily releasing some ineffective thing, that can be more harmful than doing nothing. So, you should first manage the every case of poisoning. The stabilization of the patient should be the primary goal. Symptomatic relief is the prime management goal, and thereafter, if the diagnosis has been confirmed, thereafter we should proceed for the accurate management. Otherwise, we should wait and take the further consultation from the seniors or take the advice of the senior doctors. This should be the treatment strategy in case of the poisoning. Then antibiotics use is also up to the question, that whether the what all other infections that could have happened in the patients or other complications. According to that, we have to decide that antibiotics shall be started or not, and the senior consultation should always be taken. In this way, the management of the poisoning with the ammonia shall be done. Then the certain facts of the medical legal importance, that is the manner of death. It is important to note that most ammonium poisoning cases are the suicides due to the distinct smell. Here it is important to note that in case of ammonia, most ammonia poisoning cases are due to the suicide and not accident, and it has the peculiar smell. So, the everyone will have the knowledge that there is some toxic gases, so they will avoid going there, and they have the distinct smell that causes the less accidental poisoning with ammonia. Its properties makes it unsuitable for the murder as it is very clearly recognizable poison. Then its uses in the robberies. Then another use of ammonia is that it is used in the robberies. Ammonia spray are used to incapacitate the victims during robberies, causing serious eye injuries. Then food contamination may be with the ammonia. In one of the reported cases, students fell ill after eating the chicken tenders contaminated with the ammonia. Patients presented with the stomach ache that are seen in the 82% of cases, headache in 61% of cases, nausea in the 41% cases, and vomiting in 23% of cases within 1.5 hours of having the lunch contaminated with the ammonia. In this case, the contamination stemmed from the leak from the warehouse of the ammonia refrigerant with the levels as high as the 2468 ppm detected in the uncooked chicken tenders. In this way, the ammonia intoxication in food was recorded. This all we must know about in case of the ammonium intoxication. So, with this, we will finish today's class. We shall continue in the next class. Thank you.